During the last years, we have learned a lot on the genetic events occurring in AML occurrence. So it has been based mostly on deep sequencing on genome of blast cells in a variety, in large population of patients. And what we learn is that it's not only a single disease. It's a lot of different subsets based on genetic abnormality. That's the first important point. The second one is that this mutation could have been classified as, let's say, driver mutation and secondary or passenger mutation. And this is really important from the therapeutical point of view because it's obvious that probably targeting driver mutation could be more efficient than targeting passenger mutations. The occurrence of AML is, in some patients, especially older patients, could be preceded by a phase of myelodysplasia or of disease in the bone marrow, which is not still an acute leukemia. So this is called Myelodysplastic Syndrome. And in older patients, it's quite frequent that AML is occurring after a phase of myelodysplasia. And for a long period of time, this has been recognized, but we do not know how really to define and to discriminate this patient as compared to de novo AML occurring in patients without myelodysplasia. Because to know that there is a previous myelodysplasia, you have to have an access to previous bone marrow examination, which is not the case in most patients. So then after, the doctors used to call a secondary leukemia a leukemia when at diagnosis there is some myelodysplastic changes in the different hematopoietic lineages. And the true definition of what could be called secondary leukemia came when you know the mutation and the mutational status. And now, based on the mutational status in each individual patient, it's more easy to define what is really a secondary leukemia as compared to a de novo leukemia. So mutational analyses have been very useful to solve this issue.
There happen to be about 30 or so recurrent mutations in AML. The average case has about 3 to 5 of those. However, right now, for prognostic purposes, the average clinician should send off studies to assess the status of mutations in the following 4 genes: Flit3, c-KIT, NPM1, and CBP alpha, because those are the ones that have current prognostic importance. Specifically, biallelic mutations in CBP alpha have a favorable prognosis. Mutations in NPM1 have a favorable prognosis. Mutations in c-KIT in those who also have a core binding factor cytogenetic abnormality, including inversion 16 or 821 translocations, have a negative effect on that subgroup. Finally, the Flit3 internal tandem duplication, or ITD mutation, which occurs in about 25% of AML patients overall, has a clearly adverse effect on prognosis. Approximately 30% of AML patients, blasts, can be shown to harbor a Flit3 mutation. There are 3 subtypes of Flit3 mutations. The more common subtype, which accounts for approximately 3/4 of all Flit3 mutations, is an internal tandem duplication mutation, or a repetition of between 3 and over 100 amino acids in the juxtamembrane region just inside the cell relative to the cell membrane. This type of mutation carries an adverse prognosis. Patients who have it tend to relapse at a higher rate than their non-Flit3 mutant colleagues and also have an inferior overall survival. The other type of mutation, which occurs in 25% of those with a Flit3 mutation, or about 10% overall of AML patients, is called a Flit3 TKD, or Tyrosine Kinase domain mutation. The prognostic impact of that mutation is controversial. Some studies have shown it to be adverse, others have shown it to be favorable.